Thank you. Thank you for the invitation. I am delighted to be here in India. Hyderabad is my hometown, just so you know. I always introduce myself as coming from Hyderabad. Just so happened that I had nothing better to do other than leave the country after medical school, and so I ended up in New Orleans, and in the process of moving out to Tampa, to the University of South Florida as the chairman of the department starting next month. We also have an institute that we helped establish in Hyderabad, Ananda Institute, where we are in the process of training glaucoma fellows. Glaucoma is my passion. I do a lot of other surgeries, but for whatever reason, I love glaucoma. And I think a lot is to be said about glaucoma, especially in the Indian setting. These are all my financial disclosures. Nothing that I do or say here has anything of any relevance to those financial disclosures. Acute angle closure glaucoma, you already heard many talks probably. The gist of my message is going to be very simple and short. I'm going to present to you two cases. One, acute angle closure glaucoma, one chronic angle closure glaucoma / plateau iris that present to my practice and how I manage them as we speak today, okay? You know how these eyes present, they are all classically have small eyes, large lens, shallow chambers, narrow angles, pupillary block mechanism, iris bombay, angle closure, and you develop this acute attack, and the patient presents to you with the steamy cornea. And the traditional standard of care treatment for somebody who's presenting to your clinic with acute angle closure glaucoma is what? You try IV mannitol or oral pills, acetazolamide to reduce the intraocular pressure, then topical medications, pilocarpine, aqueous suppressants. When the cornea clears up, hopefully it does, you try the YAG-PI, and the YAG-PI to the fellow eye. If the attack doesn't break, then you think of surgical maneuvers. What I do in my practice is slightly different. So here is case number one, a 45-year-old oil trader. He's a 13 diopter hyperope. His cousin happens to be an general ophthalmologist. She did a routine dilated fundus examination, put him in angle closure attack. 3 days later is when the patient was referred to me. By this time, he's been throwing up for 3 days continuously in severe agony and pain. Steamy cornea, vision was count fingers. And he just could not control he could not take the pain anymore. He already had oral Diamox and all the drops that you can imagine by his cousin. What I do is pretty simple. I take a 30-gauge needle. I put these patients at the slit lamp as soon as they come to me with angle closure attacks. Put the patient at slit lamp. Of course, you want to do a betadine prep, a topical lidocaine application, lid speculum, and 30-gauge needle at the slit lamp. You enter the anterior chamber through clear cornea, and all it takes is literally 2 minutes of the needle in the anterior chamber, a few drops of aqueous coming out, and the attack is broken. And the pain is gone, and the patient stops vomiting. And once that happens, you can do whatever else that you want to do. I guarantee you, I've done this for almost 10 years now. Yeah, literature is insufficient. Never had a single complication doing this procedure. Cornea clears up, patient is happy, they don't have any more pain. Then what I do is to take these patients into, to do the next procedure, which is arthroplasty. Organ laser arthroplasty has been around for quite a bit, but underutilized by ophthalmologists. It's such a simple procedure. It's almost atraumatic compared to YAG-PI. It opens up the angle, that's it. And once it's done, the angle is open, the attack is broken, you can do your YAG-PI. You know, back where I come from, we have a lot of African American eyes, and the iris is extremely thick, and doing a YAG-PI sometimes takes more than one setting. And it releases a lot of pigmentation. On the other hand, arthroplasty, as is being done here, it's all number threes. If you notice there, 0.3 milliwatts, 300 micron spot size in 300 milliseconds, and 30 spots going around 360 degrees. I don't even apply a lens. You don't even need to have a lens. All you need is your routine organ laser in your clinic, and you can accomplish this. I like to do simple things. I'm not a complex person. I don't like to buy expensive equipment for my clinic. 30-gauge needle probably costs you what, 10 rupees or maybe less than that in India at this point in time. Instead of using IV mannitol, Diamox, which are expensive, and the patient is sitting there in the clinic and every hour pressure checks, which is what I, as a resident, used to do back in the day. This is what I do. And then step number 3, treat the patient for inflammation and prevent infection with some steroid and use whatever glaucoma medications that are needed, plus or minus pilocarpine and oral acetazolamide. And finally, you take the patient when the eye is quiet, take the patient to the operating room a week or 2 weeks later and take the cataract out. Once the lens is out, you will never have another attack for this patient. This is one glaucoma that I can confidently tell you, you can cure this disease process. Once the lens is taken out, there is no need to follow up on these patients if the patient misses. I mean, I would like to still follow these patients, but this is one glaucoma wherein you can offer a cure and the cure is done and they will not have, they can develop open angle glaucomas at a later date, that's a different story, okay? But acute attacks are not going to happen. Here is how I do cataracts. I mean, the technique is pretty similar. All of you are excellent cataract surgeons. I don't need to show you how to do a cataract surgery, except somebody with the acute attack, the iris is atrophied, it's kind of floppy. There could be cynical adhesions between the lens and the capsule and the pupillary margin. And also, you will have cynical adhesions between between the iris and the angle structures. And so, take your time, clean up, break those adhesions both between the lens and the pupillary margin, and performing goniosynechrolysis. This is one way. This is a cheap way of doing goniosynechrolysis. Use your viscoelastic cannula as you inject this is called viscodissection. Inject some visco and go do an anterior-posterior motion with the viscoelastic cannula tip. You can break 360 degrees using your paracentesis and the cataract wound site, and the attack is broken, right? Now, last step, obviously, you want to take care of the other eye. And when the other eye is done, what do? I do offer PI for the other eye, and when the time comes, if the angle is still narrow, I take the lens out. So, because the history of this, natural history of these eyes, they will develop an attack in the other eye if you leave it alone. So, since you took the lens out in one eye, I go ahead and take the lens out. For all of these things, the argument is why put the patient at risk? If you're a competent cataract surgeon and a competent anterior segment surgeon and your complication rates are minimal, in my hands, they're pretty low, or at least I think so, and I go ahead and offer it and I take the lens out, and after that, these patients are cured. What do I do for chronic angle closure glaucoma? These are hyperopic eyes. We just heard a lecture on this, large lens, shallow chambers, narrow angles, creeping angle closure, and as I learned today, 50% of all glaucoma patients in India, they have chronic angle closure glaucoma. Just as in the United States, this is the most commonly missed glaucoma. I mean, I can't tell you how many times senior ophthalmologists in private practice miss this entity and then send the patient after they lost a significant amount of vision, or they would end up doing a glaucoma procedure such as trabeculectomy, not knowing that there is angle closure. And the shallow eyes with underlying thick lens and cynical adhesions between the lens and the angle, it is a setup for people to develop complications following trabeculectomy. More than likely, you will end up with a complication of flat chambers or malignant glaucoma, all of which could be avoided if you know the pathophysiology. So gonioscopy, like when I said, it should be practiced on every single patient. It's almost criminal in my mind for you not to do gonioscopy when the patient comes into your clinic. Do a gonioscopy. It takes you less than two minutes to do a proper gonioscopy. Learn the art of gonioscopy, and it's so useful for the patients. So traditional treatment for chronic angle closure glaucoma, use your aqueous suppressants, pilocarpine. You can do your PI and wait out and see what happens. And then trabeculectomy if none of those work. So the issues with traditional treatment, side effects from topical and oral medications. Now, like when I said 60% of the patients probably are controlled with just these medications, so you can sit out and wait out and watch. But if the pressures are not under control, or if there's a pre-existing optic nerve damage and the vision fields are far advanced damage and the target pressure is low, I don't want you to wait around thinking some miracle is going to happen for these patients. So trabeculectomy complications like flat chambers, cataract formation, malignant glaucoma there. And a lot of times, in my experience, by the time the patient is referred to me because they've been sitting out on these patients on pilocarpine, they end up with these dense brunescent cataracts, and these cataracts become more difficult for you to take them out, and post-op pressure spikes. So here is a patient, monocular patient, who was referred in with pressure 35 on 3 drops, gonioscopy, anterior iris insertion, UBM, angle closure, most often caused by anteriorly positioned ciliary processes, i.e. plateau iris is what this particular patient had. And here is how I manage this patient with plateau iris syndrome. So this patient already had iridoplasty. You do want to do and a PI. You do want to do a PI in every single plateau iris syndrome patient. This is one clinical way for you to rule out plateau iris versus chronic angle closure glaucoma. Plateau iris itself can lead to chronic angle closure glaucoma, but not all chronic angle closure glaucomas have plateau iris. Now here is a neat way of doing gonioscopy, goniosynechal lysis. This is a microforceps. You introduce through your cataract wound site, and then grab the iris gently towards the root of the iris and gently peel. It can bleed. Don't panic. If it bleeds, that's okay. You can wash it out. So using 2 or 3 sites of paracentesis, you can almost do 360-degree goniosynechal lysis this way, and then wash out the anterior chamber and look at the angle. If the angle is completely wide open, you don't need to proceed to do anything else. But here you can see the root of the iris has bumps in it, indicating that the ciliary processes are turned anteriorly, pushing the iris, telling me that this patient has definitely plateau iris syndrome. In those cases, the plateau iris syndrome, what do? I introduce a ECP or endocyclophotocoagulation probe and zap the ciliary processes 180 degrees and open the iris. It does 2 things. It rotates the ciliary processes away from the root of the iris and takes away that problem of angle closure by mechanical pushing up mechanism. And 2, it will also control the pressure. If you want to control the pressure, what you want to do is apply the diode laser in the valleys. Okay, that's where the maximum aqueous production occurs. Even in chronic angle closure glaucoma, this is a great technique for you to do. Take the lens out, do a goniosynechal lysis, and then ECP into the valleys. That will control the glaucoma. If in spite of these mechanisms, the pressure is high, then what you want to do is you see how nicely the patient is? The angle is wide open now, the lens is out, the chamber is done. At the end of this, if you do these kind of procedures, you want to do some kind of an anti-inflammatory material in the AC. I use Kenalog, diluted Kenalog, and I inject it into the ciliary processes area and the sulcus. It will stick to the ciliary processes that are inflamed, control the postoperative inflammation, so you don't get CME and post-op inflammation in these patients. So the treatment Ramesh, for any of this is PI, myotics,
Dr. Ramesh,
and so on and so forth.
Time is up.
Yeah, I'm done. Thank you so much.